Welcome to the Deep Dive. We're here to unpack the latest research and give you the key insights fast.
Glad to be here.
Today, we're tackling something really complex, often quite misunderstood in the world of food allergies. Food protein-induced enterocolitis syndrome, FPIES for short.
Yeah, and it's a really critical topic. FPIES is, well, it's a non-IgE cell-mediated food allergy.
Okay, so for listeners who know a bit about allergies, that non-IgE part is key, right? Exactly. It means FPIES doesn't follow the usual allergy script.
Yeah.
You don't get those immediate reactions, the hives, the quick swelling. And that makes it, frankly, really tough to spot sometimes.
Right. So our deep dive today is grounded in the first ever international consensus guidelines on FPIES, plus some newer research looking at its less typical forms.
Our goal is really to get past the basics and give a solid, clear picture of this condition.
And let's start with the detail that really defines FPIES. The reaction timing. It's delayed.
That's the absolute core of it. You eat the food and nothing happens right away. The symptoms, they don't really kick in for maybe 1 to 4 hours. And when they do kick in,
it can be dramatic and scary. That delay is why it's so confusing. The severe symptoms, when they hit, look a lot like a bad infection, almost like sepsis.
Sepsis, wow.
Yeah, we're talking repetitive, relentless vomiting, often projectile. Kids can become incredibly pale, really lethargic. And in a significant number, maybe 15% or even more, it can progress quickly to hypovolemic shock.
Hypovolemic shock. That's the body losing fluid too fast, leading to collapse?
Precisely. All that vomiting, maybe later diarrhea too, leads to severe dehydration. The body just can't cope with that rapid fluid loss. It becomes a true emergency needing fast intervention, usually IV fluids.
Okay, let's unpack this. What really separates these FPIES reactions from IgE allergies, the ones most people think of as anaphylaxis?
Well, like you said, it's the mechanism. No IgE antibodies driving that immediate response. So you just don't see the typical skin stuff, no hives, no itching, or the immediate breathing problems like wheezing or throat swelling.
It's all happening inside, mostly in the gut.
Primarily gastrointestinal and systemic, yeah. Different immune cells are reacting in the gut lining, causing this delayed but severe inflammation.
So the classic presentation, that's acute FPIES, usually happens if the food isn't eaten regularly.
That's the one, yes. Intermittent exposure or re-exposure after a break. And that 1 to 4 hour window is when you see the main event, that repetitive, really forceful vomiting.
You mentioned projectile.
It can be, and frequent. In severe cases, a child might vomit 4 or 5, maybe more times. Along with that, you get this striking pallor. They look really white and just profound lethargy. They're wiped out.
Is diarrhea always part of it?
It often follows, but later. Maybe 5 to 10 hours after eating the food. It can be watery, sometimes even have some blood in it, but the vomiting is usually the first and most dramatic sign.
And things usually settle down within about 24 hours.
Typically, yes. But the danger zone is that period of intense vomiting. That's when the dehydration, the potential drop in body temperature, hypothermia, and low blood pressure or hypotension can develop really fast.
Those are the big red flags for severity.
Absolutely. These markers mean you need medical help quickly. We really need to emphasize this isn't just a bit of a tummy bug. The dehydration can lead to metabolic acidosis. The body's chemistry gets thrown off balance. It's a genuine emergency needing aggressive fluid replacement, usually IV hydration, to get them stable.
What's fascinating here is FPIES isn't just one thing, is it? There's this other form, chronic FPIES. How does that differ?
Chronic FPIES is sneakier. It tends to happen only in very young infants, usually under 4 months, who are consistently getting the trigger food every day. Mostly cow's milk or soy formula.
So not a big dramatic reaction, but something else.
Right. Instead of that acute blow-up, they develop ongoing sort of intermittent vomiting, persistent diarrhea, and crucially, they start failing to thrive. They don't gain weight properly. They might even lose weight. It's insidious.
That sounds awful. Just chronic gut issues leading to poor growth.
It is. But the good news, relatively speaking, is that if you figure out the trigger, say, the cow's milk formula, and switch to a hypoallergenic one, the symptoms usually clear pretty quickly, within maybe 3 to 10 days.
And is there a link back to the acute form?
Yes, and this is key for diagnosis. If that infant avoids the food, gets better, and then later on, you reintroduce that same food, bang. They typically have a classic acute FPIES reaction. It confirms the sensitivity.
Okay, so we have acute, we have chronic. Then things get even more complicated with something called atypical FPIES.
Yes, atypical. This is where the immune system seems to be, well, hedging its bets, you could say. Clinically, the patient have that typical delayed FPIES reaction, the lethargy.
But
But
Yeah.
they also show signs of IgE sensitization to that same food. So they'll have a positive skin prick test or blood test for specific IgE antibodies like you'd see in a classic allergen.
Wait, so they have the markers for a fast IgE reaction, but the symptoms are the delayed FPIES type. How common is that?
It's surprisingly common. Some studies suggest maybe up to 25% of patients might fall into this category. Looking at triggers in a big registry, it was about 12% of evaluated triggers. And the foods involved, often the big IgE players, egg, peanut, oat, milk are frequently cited.
Does having both types of reaction potential change things for the patient?
It seems to, yes. Atypical FPIES is often linked with sticking around longer. It takes these kids longer to outgrow it, to develop tolerance. There are even cases reported where someone might switch from having an IgE allergy to FPIES, or the other way around. It's complex.
And I remember the sources saying this isn't just a kid thing anymore.
Correct. Adult onset FPIES is definitely being recognized more and more. Often it presents as acute FPIES, and the trigger is frequently seafood, fish, or shellfish, even in people who ate it without problems their whole lives.
And can adults get the chronic form too?
It's less common, but yes, there are documented cases. Chronic adult FPIES linked to things like egg, beef, even salmon.
Okay. With all these variations, acute, chronic, atypical, adult onset, how do clinicians actually figure out it is FPIES? Here's where it gets really interesting.
Well, the new international guidelines are very clear on this. Fundamentally, FPIES is a clinical diagnosis,
Meaning
it relies almost entirely on getting a really careful, detailed history. Listening to the story of what happens, those characteristic delayed symptoms, and importantly, seeing that things get better when the suspected food is removed.
So the story's everything, but what about testing? Where do oral food challenges, OFCs, come in? They sound risky.
OFCs are considered the gold standard, but they're used very specifically and cautiously, primarily for two reasons. One, maybe to confirm the diagnosis if the history is a bit unclear, but much more often they're used down the line to see if the child has actually outgrown it.
But you mentioned before, reactions can be severe, needing IV fluids. How safe is deliberately giving the food?
That risk is exactly why OFCs have to be done under strict medical supervision, never at home. You need a setting where you can give IV fluids immediately if needed, because, maybe up to half of challenges that trigger a reaction might require fluid resuscitation.
Wow, 50%.
It underlines the potential severity. The standard protocol usually involves giving the food calculated by protein amount in maybe 3 doses over about 30 minutes, and then watching closely for at least 4 to 6 hours.
Is there any progress towards a less risky test, like a blood test or something?
That is the million-dollar question. Right now, there isn't a specific lab test or procedure that definitively says this is FPIES. Finding a reliable, non-invasive biomarker is probably the biggest unmet need in this field. We rely on the history and, when necessary, the supervised challenge.
So, okay, if someone does have an acute reaction, either at home or during a challenge, what's the absolute first thing to do?
Priority number 1, without question, is fluids. Aggressive isotonic fluid resuscitation. That means getting IV fluids in quickly boluses of normal saline, usually 10 to 20 milliliters per kilogram of body weight, given rapidly. That's crucial to stabilize their blood pressure and circulation.
Is there anything to help with that awful vomiting?
Yes, there's growing evidence for using ondansetron. It's a potent anti-nausea drug, a serotonin blocker, often known by brand names like Zofran. It seems quite promising for helping to stop that relentless vomiting in acute FPIES.
So that's becoming more standard.
It's being used more, though we probably still need more large-scale trials to fully define its role. But anecdotally and in smaller studies, it seems helpful. Sometimes, for very severe reactions, doctors might use steroids too, but that's less well established in the guidelines.
And just to be crystal clear, EpiPens, the epinephrine autoinjectors used for IgE allergies.
Generally not the primary treatment for FPIEs. Unless, of course, the person has a known, separate IgE allergy that warrants having one. But for the FPIEs reaction itself, the core problem is fluid loss and shock, which needs fluids, not primarily epinephrine.
That's a really important distinction for families and emergency responders to understand.
Absolutely critical. The presentation drives the treatment.
Okay, if we connect this to the bigger picture, managing FPIEs day-to-day must revolve around triggers and diet, right?
Completely. The main long-term strategy is strict avoidance of the trigger food or foods. And this really needs guidance from a dietitian or nutritionist who understands FPIEs.
What are the most common culprits we see?
Globally, the big ones are cow's milk and soy, especially in infants. Then grains, rice, and oats are very common triggers.
Yeah.
But the sources do point out interesting geographic differences. Like fish-induced FPIE seems much more common in places like Italy and Spain compared to, say, the U.S.
And avoiding major foods like milk, soy, or grains, especially in young kids, must raise nutritional concerns.
Huge concerns. It puts children at significant risk for deficiencies. We worry about getting enough energy, protein, vitamins like A and D, calcium, iron, zinc. It's a real balancing act to ensure they grow well while avoiding their triggers.
What about breastfeeding? If a baby has FPIES, does the mother need to cut the trigger food out of her own diet?
That's a common question. Generally, the guidelines say routine maternal elimination isn't necessary if the exclusively breastfed baby is thriving. Most infants don't seem to react to the very small amounts of food protein that might get into breast milk. Of course, if the baby is reacting even with exclusive breastfeeding, then a maternal trial of elimination might be considered. But it's not the first step, usually.
When do things get better? Do kids outgrow FPIEs?
Most do, thankfully. But how quickly varies a lot depending on the food. Cow's milk and soy FPIES often resolve a bit earlier, maybe around age 3 on average, based on pooled data, although some centers in the U.S. are reporting it might be taking longer now.
And other foods.
Grains and other solids often take longer to outgrow. The average age of resolution might be closer to 3.5, 4 years, or even older in some cases.
And what about that atypical FPIES group, the ones with the IgE sensitization too?
Ah, yes. That group generally has a tougher road. The data suggests they tend to have a more protracted course. For example, kids with FPIEs to cow's milk, who also have a positive skin test, might not outgrow it until they're much older, potentially even into their teens, like past age 13.
That's a long time for families to manage this, which brings us to something really crucial, the impact beyond just the medical side, the psychosocial burden.
This is so important and often overlooked. The stress on families dealing with FPIEs is immense. Studies show caregivers report worse health-related quality of life compared to caregivers of children with typical IgE food allergies.
Why do you think that is? Is it the delayed reaction?
That's a huge part of it. The unpredictability.
Yeah.
The delay means after every meal with a potential trigger or any new food, there's this hours-long waiting period filled with anxiety, wondering if this time will be the one that lands them in the emergency room. And the reactions, when they happen, look so severe, like a catastrophic infection.
I can only imagine that constant vigilance. It must be exhausting.
Utterly exhausting. Families talk about intense stress, constant worry. It affects everything, deciding about childcare or school. Eating outside the home becomes terrifying. It puts strain on relationships. Many families basically feel tethered to their home or very close to a hospital, just in case. It really alters the whole family's life and routines.
So what does this all mean when we boil it down?
I think the key takeaway is that FPIES is fundamentally different because it's non-IgE-mediated. This leads to these distinct patterns, the acute, the chronic, and now this complicating atypical picture with IgE overlap. And because we lack a simple diagnostic test, that careful clinical history is absolutely paramount.
It's about recognizing the patterns, listening to the story.
Exactly, and understanding the potential severity and the specific management needs, like focusing on fluids, not necessarily epinephrine.
Right. Which brings us to our final provocative thought for you, our listeners, to mull over. We know from research into IgE-mediated allergies, like milk or egg allergy, that sometimes introducing extensively heated forms of the food, think milk or egg, baked into a cake or muffin, can actually help kids outgrow the allergy faster.
That's been a big advance in IgE allergy management, yes. Introducing baked milk or egg earlier.
So the big question now, a major research priority highlighted in these new guidelines, is this. Could children with FPIES to cow's milk or egg potentially tolerate these extensively heated forms safely? And crucially, if they can, might regularly eating these baked forms actually speed up the resolution of their FPIES too?
That's the frontier, isn't it? Moving beyond just strict avoidance, wondering if there's a way to actively guide the immune system towards tolerance, like we're starting to do for IgE allergies. If baked egg or milk introduction could shorten the course of FPIES, well, that would be a game changer for these families.
A potential pathway from this incredibly burdensome condition towards tolerance? Okay. Something definitely to watch in FPIES research.